Okay, we're going to move on and we're going to look at some of the surgical interventions, and then we're going to review some of the complications. If we're looking at surgical fracture treatment, we'll hear the term open reduction internal fixation, in which we use pins, screws, rods, plates to maintain the reduction of the bone. Typically, your patient is able to regain their mobility more quickly than perhaps a patient who is in a cast, or definitely one who's in traction. But we do have an increased risk of infection because of the incision and potentially the hardware. The hardware is left in general cases, and after surgery the only thing that you're going to see on the outside is the incision itself. Post-operatively, your patient is going to have a dressing, perhaps an ACE wrap, a splint, maybe even a cast if we need additional support. Your physician is going to change that original dressing. We talk about ORAF. Here's some of the advantages. We've got earlier ambulation, shorter hospitalization, restoration of normal bone shape. Doing an ORAF can get this person out of bed and moving much more quickly, and it decreases the complications of immobility. Another alternative treatment is external fixation, and we use this for complicated fractures or when we have a fracture with extensive soft tissue injury. We get the same type of fracture reduction. We have percutaneous pins which are implanted into the bone through a small incision which will hold that fracture in place, and they're held by the external frame. That whole frame helps prevent any bone movement. The whole apparatus is put on during surgery, and through the use of this, we can then manage that soft tissue injury as well. Our advantages: we've got minimal blood loss, early ambulation, again, permits easy access to wounds, and it can promote the healing with skin and tissue damage. The physician is going to adjust the hardware to make any further alignments of that bone that need to be taken and need to be done in the process of healing. Disadvantages: your patient is at higher risk for a pin site infection. Pin care is going to be done by you as a nurse as part of your plan of care based on that physician protocol. The patient is definitely at risk for osteomyelitis, so be sure that you know the symptoms of infection and the complication of osteomyelitis, including your lab values. Do you have a temp greater than 101? What does that wound look like? Is it edematous, red, tender to palpation? Do you have pain, localized pain that's constant, a pulsating sensation? As far as labs, do you have increasing WBCs? Do you have an increasing ESR or SED rate? And do you have compromised circulation? Another common, or rather, shall I say, uncommon method for fixation, but certainly is used in some situations, is circular external fixation. This is often used for congenital deformities, or if we have some very complicated comminuted fractures, so that we've got a lot of bone fragments. It can also assist with stimulating bone growth in someone with poor fracture healing. Promotes rotation, angulation, shortening or lengthening, or widening of the bone, and wound healing in the process. If we're looking at fixation devices and the nursing care that's required, they are much the same as many that we have discussed before. Again, assessment of neurovascular status. Your patient is going to go home with this, so he is going to need teaching on also how to watch for neurovascular status in that extremity. Looking at mobility issues, diet, monitoring for signs and symptoms of infection, and teaching with your patient related to that. Looking at the pain level and medicating the patient as needed, and instructions for their pain management at home. Now, certainly with an external fixation device of this type, there's the body image. So you need to discuss that with the patient, make sure that they are accepting of the device because this is generally on several months at a time. You also need to teach the patient how to manage the movement of the device itself. It's really not good to use that as a lever or a handle. You need to handle that extremity carefully underneath, supporting it with any kind of movement. Assistive devices are also commonly used by our musculoskeletal patients, and you may be involved in doing some of the teaching with these. Oftentimes physical therapy will be very involved with your patient, but depending the type of setting you're in, you may need to be assisting with setup and patient teaching. So if you look at crutches, if you're sizing crutches, it gives you direction on sizing these. They should be 5 centimeters below the axilla. This is to prevent nerve damage for your patient. So indeed, you shouldn't be hanging on those crutches like it always looks fun and we kind of do that swing through type of activity. There's something called a 3-point gait, a 4-point gait that your patient might be using depending on the instructions and depending on the type of injury that they have. And then they also need stair training, which you may indeed be involved with. Some other devices that you might be using, a platform walker. If your patient has an upper extremity injury, they may need to support that upper extremity and yet still need a walker. So they will have somewhat of an arm support or platform on one side, which will take weight into a larger surface area, and they can still use the walker. You may have the quad or the hemi-cane, the 4-prong cane. The cane goes on the unaffected side. When you're using a cane as an assisted device, you should have no more than 30 degrees of elbow flexion as you're setting that device up for the patient. We're going to highlight just a few of the complications of musculoskeletal trauma. The first one is compartment syndrome, which, if you remember, it's a condition which we have increased progressive pressure within a confined muscle compartment, and that is going to compromise the circulation and function of the tissues within that space. This is a limb-threatening complication potentially. It generally occurs following trauma, but it can also occur with other incidents. We've, for instance, had runners at times that will develop a compartment syndrome. Compartments, if you remember and you think about it from your A&P course, are inelastic sheaths of fascia that surround groups of muscles, blood vessels, and nerves. This complication is going to occur most commonly in the lower leg and your forearm compartments. So the next slide is going to take a look at some of those compartments. So all of the black areas are the various muscle compartments that you would see with an upper or a lower extremity. With acute compartment syndrome, we've got increased pressure within one or more of the compartments, reducing the circulation to that area. The cause of this can be internal or external factors. We can have increased compartment contents. So they can be increased, such as in the case of blood or fluid accumulation. We can have causes other than musculoskeletal trauma. We might have massive IV infiltrates, burns, insect or snake bites could be other examples. External causes could include pressure from a very tight, bulky dressing or a cast. The next slide is going to talk about the pathophysiology and what we call the ischemia-edema cycle of compartment syndrome. So you'll see that we get ischemia, our capillaries dilate, so we get increased pressure. Those capillaries become more permeable, related to the release of histamine from that ischemic muscle. Plasma proteins leak interstitially and cause edema. Edema causes nerve pressure, blood flow is reduced, and it causes additional ischemia. This cycle will continue unless we break that cycle with an intervention. When you know that your patient is at risk for complications such as compartment syndrome, you need to provide excellent assessments. So the 6 P's are one way that you're going to approach the assessments of your patient with potential complications of compartment syndrome. Pain. Is that pain increasing? Was it previously under control, but it is totally out of control? Your patient has been medicated with what should be very acceptable levels, and this is very uncharacteristic pain. Do they have a lot of increasing pressure? It just seems to be getting tighter and tighter within that wound area. Was the extremity previously pink with good color and now it's getting very pale? Is there pulselessness? Or is it diminished? You don't want to wait until that pulse is absent, so you need to stay on top of those assessments. Paresthesia might be the first sign of a problem. Do you have some type of abnormal numbness or tingling? Paralysis is definitely a late sign, and you do not want to get to this point. Is your patient suddenly unable to move the extremity? Labs that you might be monitoring are CPK or a CK and a potassium. If you have muscle damage, your creatinine kinase is going to increase. Okay, it's going to increase related to that cell damage. You're going to need to assess and monitor renal status and cardiac rhythms. Notify your physician when you start to see any of these assessment parameters in your patient. Compartment pressure can be measured with a special device. A key, remember, in managing compartment syndrome or the patient that you think has the potential is that you elevate that extremity only to heart level, not higher. Excuse me. Several complications of compartment syndrome would include myoglobinuria renal failure or rhabdomyolysis. This occurs when large compartments or multiple compartments are involved. That injured muscle will release myoglobin into the circulation, which then can occlude the distal convoluted tubule, and it precipitates renal failure. This protein has a direct toxic effect on the kidney. Potential amputation is a realistic outcome for these patients. Within 4 to 6 hours of the injury, the damage can be significant enough that there could be a need for amputation. Infection from necrotic tissue may be severe enough that limb amputation may also be needed. We can have irreversible neuromuscular damage. So if it's not treated within approximately 4 to 6 hours, extreme complications and extreme changes for this patient can occur. Treatment for compartment syndrome. If it's caught early enough, non-surgical interventions can be effective to relieve pressure by elevating at heart level and continued assessment. If we need to do surgical management, the procedure would be a fasciotomy. So the surgeon is going to cut the fascia to relieve pressure, which is going to restore circulation to that compartment. The wound then remains open until the pressure within the compartment normalizes, and then it's going to be sutured closed. The patient would need to go back for surgery for wound closure and potentially beyond that for muscle or for skin grafts to close that entire fasciotomy site. A second complication that we're going to take a look at quickly in review is fat emboli. Fat globules from the bone marrow are released into the bloodstream. They become entrapped in the circulatory system of the lung capillaries and they block the circulation. They're most common with fractures of long bones or multiple fractures. They typically would occur in 12 to 48 hours after injury. So a common site, a common fracture would be a femur fracture, which is a fairly large fracture. We need to carefully look at assessment. So our most common initial symptom that we're going to see is altered mental status. You will also find a very good table in IGGI that talks about key features and the comparisons of fat emboli with pulmonary emboli. And you should take a look at those to review them before class. Also, look at the labs that are listed here, whether they would be increased or decreased, and the values that you're going to see related to your patient with these complications. If we're looking at treatment, we are looking at oxygen, IV fluids, fracture immobilization, and highlighting no anticoagulants. Anticoagulants are not used in the management of fat emboli. Altered mental status related to low oxygen level would be an early sign of changes in your patient and potentially signal you to this complication. Third complication that we see with our musculoskeletal patients is DVT and PE. Blood clots can develop due to some sort of injury, or venous stasis, or hypercoagulability. So that Virchow's triad that we talked about previously. DVT is the most common complication of lower extremity trauma. Your pulmonary emboli can result from a DVT in the lower extremity or pelvic fractures if that then breaks loose and travels to the lungs. So remember that thrombus formation is associated with stasis, endothelial injury, and hypercoagulability, which are the key points of Virchow's triad. This is why the preventative measures for DVT are so important. Assessments, you can see the key assessments here. If you look at the treatment, compare the treatment for PE to the treatment that we just looked at for the fat emboli. You will see that anticoagulants are on this list. In addition, we may need to use a vena cava filter for this patient or do an embolectomy. Prevention is key for these patients. Post-op exercises such as foot pumps or ankle circles, using the TED hose, the sequential compression devices, or the AV impulse devices. Make sure that your SCDs and AV impulses are on most of the time, even if your patient is up in the chair. If these devices are off for 8, 16 hours, you need to discuss whether you are going to put those devices back onto that patient or not. The first sign that you turn that device on and that compression occurs, which is fairly high level, if you have a clot that has now developed in the last 8, 10, 12 hours, the compression of that device could now force that clot loose. So if those devices have been off for long periods of time, you need to determine if you are to really truly replace those devices on that patient again. That's why it's so important to continually maintain that device. You need to take them off once, twice a shift for short periods to allow for rest on those extremities, but they need to be replaced. Anticoagulants and antiplatelets may be used for that patient. Aspirin, Plavix, warfarin, Lovenox, other types of low molecular weight heparins, and that can vary with physician preference. This is the end of part 2 of the presentation on fracture management. Please review these 2 sets of voiceovers and the PowerPoint so that you have this information in review for class this coming week.